So good morning, everyone online. Thank you once again to Dr. Jain and to the Melap team for inviting me to this talk. So today I'll be talking about the Cbc parameters, which are new to the conventional one. So Cbc is, as Sir has already told, we all know that it's a widely used test. It's the most frequently ordered test in our labs. And the evolution of Cbc has gone through a long journey. Right from the times when we used to do the counts on Newbar's chamber prior to 1950s, and then the Coulter's principle, and then came the three-part analyzers, then the five-part differential analyzers in 1970s, and now there has been such a boom in the technology of hematology analyzers that not only we have six-part analyzers, but we have many new parameters added to the conventional parameters of Cbc. Also, the existing parameters have been improved in their accuracy because of the improvement in the technology. So today we'll be talking about some of the new parameters which are reportable, and there are many others which are still in the research pipeline, and soon maybe we will get them as reportable parameters also. So what are the new parameters we have? First of all, automated reticulocyte count, both absolute as well as percentage, immature reticulocytesection, reticulocyte hemoglobin content, delta hemoglobin, immature granulocyte count, both absolute and percent, reticulated platelets, or what we call it as immature platelet section, both absolute as well as percentage, and nucleated RBCs. So first of all, talking about automated reticulocyte count. So why did we need this automated reticulocyte count? This reticulocyte count, as you all know, is a very important parameter for the diagnosis of anemias and for monitoring bone marrow response to therapy. But what we are doing nowadays was the manual reticulocyte count, which has a lot of problems. First of all, we have to make a slide. Then there is a lot of imprecision because of staining variations, because of distributional variability in the blood film, because of observer and inter-observer variability in the morphological identification of the reticulocytes. And above all these, there was a problem of counting the total number of RBCs. We count a very limited number of RBCs. So on the whole, this method is cumbersome, it's labor intensive, and it's time consuming. Moreover, the CV% of manual reticulocyte count, when the counts are low, is as much as 40 to 50%. So now what we have is automation in reticulocyte count. So what are the advantages of automation? First of all, it gets incorporated into the Cbc itself. Then all the problems like of making the slides, staining, dilution, incubation, inter-observer identification, they're all gone. Then the analyzers can count much greater number of RBCs, and this leads to better accuracy. Increased precision is seen even on very low reticulocyte counts. So the normal range of reticulocyte count, as you all know, is 0.5 to 2.5% in adults and 2 to 6% in infants. The absolute reticulocyte count ranges from 50 to 100 into 10 to the power 9 per liter. So both these give the status of erythropoiesis in bone marrow. However, absolute reticulocyte count is much more reliable indicator of erythropoiesis in severe anemias with low RBC counts. So a study done by Purnia et al. On the role of absolute reticulocyte count in evaluation of pancytopenias, it was a hospital-based study based on which they were able to divide pancytopenia cases into three categories. One, of course, was with absolute reticulocyte count normal, that is 51 to 99 into 10 to the power 9. Other category was absolute reticulocyte count less than 50. And then the third was ARC more than 100. Now, less than 50 category was again divided into two, less than 25 and 25 to 50. It was seen that all the aplastic anemia cases had ARC less than 25, and these patients were advised bone marrow aspiration for the confirmation of aplastic anemia. While in cases of ARC 25 to 50, the main cause was nutritional anemia. So a biochemical study of ferritin, vitamin B12, and folate could rule out this nutritional anemia, while the patients who had all these parameters normal were advised bone marrow aspiration to rule out MDS. In the category of ARC more than 100, the main lot was those of hemolytic anemias. Once hemolytic anemias, malaria, and sepsis was ruled out, then the rest of the patients were advised bone marrow aspiration to rule out infiltrative disorders. So this is how we could triage the patients for bone marrow aspiration rather than advising each and every patient of pancytopenia to undergo bone marrow aspiration. Besides these advantages, automated reticulocyte count, automated reticulocyte channel, it gives us many derived parameters like immature reticulocyte fraction, ret HB content, delta HE. So let's talk about immature reticulocyte fraction. Now, reticulocytes, they are of three types depending upon the fluorescence they emit, the intensity of the fluorescence, which in turn depends on the RNA content of reticulocytes. So depending on this, the reticulocyte region is divided into three parts. One is the low LFR or low fluorescent region, mid fluorescence region, and high fluorescence region. Now this mid fluorescence and high fluorescence region is makes the immature reticulocyte fraction. Now the HFR or the high fluorescence region has the highest amount of RNA, and they are least mature, and they constitute only about 0 to 1.4% of the total reticulocytes. The mid-fluorescent reticulocytes have moderate amount of RNA. They constitute about 1.5 to 11.3%, and the LFR is the maximum, that is 86.5 to 98.5%. And immature reticulocyte fraction is equal to HFR plus MFR. So immature reticulocyte fraction is a young fraction of reticulocytes with highest RNA content. It's biochemically more active, and it's a sensitive measure of erythropoiesis. It reflects erythropoietic activity at a very early stage. Reference range is 1.5 to 12.6%. Now coming to the clinical utility of IRF. IRF is nowadays widely being used in evaluation of anemia cases. We use it for the classification of anemia into hypoproliferative, ineffective, or hemolytic types. Especially in case of pancytopenia, IRF along with the reticulocyte count can give a picture of erythropoietic activity instead of going in for bone marrow aspirate or every time. Now this can differentiate aplastic anemia from nutritional megaloblastic anemia that presents, both of these present as pancytopenia, and the reticulocyte count is more or less equal in both. Now IRF rises before reticulocyte count, so it's the earliest indicator of marrow erythropoietic activity. Now, a study done by R. Sindhu et al. On the role of IRF in evaluation of aplastic anemia in pancytopenia cases showed that out of 172 cases of pancytopenia, those that were studied, all the 54 plus 4 cases, 54 cases of aplastic anemia, as well as 4 cases of aplastic crisis in hemolytic anemia had 0 IRF. As against the megaloblastic anemia, where the IRF value was normal. So what they deduced was 4 categories of patients of pancytopenia. The category 1 was 0 IRF with low reticulocyte count. These were the patients of aplastic anemia and aplastic crisis and hemolytic anemia. Category 2 was normal or high IRF with low or normal reticulocyte count. These were the cases of megaloblastic anemia, myelodysplastic syndrome, or acute leukemias. Category 3 was high IRF with normal to high RC. These were, of course, the hemolysis cases and cases of acute blood loss. Category 4 was high IRF with normal to low RC. These were the cases of early marrow recovery from chemotherapy or infections and megaloblastic anemia responding to treatment. So these are 2 scattergrams. You can easily see that this is a aplastic anemia case in which there is no IRF band, while here we have IRF. These are the megaloblastic anemia cases. IRF can be seen in this, while IRF, that is the mid and the high fluorescent regions, are absent in aplastic anemia cases. Now, IRF can be used as an indicator of bone marrow recovery post chemotherapy and post bone marrow transplant. Increase in IRF is an indicator of engraftment, and it precedes absolute neutrophilic count, IPF, that is immature platelet section, and reticulocyte count. Post-transplant increase in ANC to 0.5 into 10 to the power 9 per liter has been used as a successful myeloid engraftment indicator till now. However, ANC may fall during clinical and subclinical infections. So now we can use IRF. Now, doubling of IRF on 2 consecutive days predicts myeloid engraftment several days before ANC. It has been widely used nowadays to monitor recovery of children with ALL on chemotherapy. Now, stem cell harvesting in autologous peripheral blood stem cell transplantation. Here, what IRF can do is it can guide us the timing of stem cell harvesting. Now, this treatment tool is widely used in various hematological disorders nowadays. And we can predict the timing of stem cell harvesting with the help of IRF. This is a crucial thing because the patients are already on chemotherapy and there is a variable bone marrow reserve. Various parameters like CFU-GM have been used for this purpose, but the quantification of CFU-GM requires 2 weeks to obtain the results. Peripheral blood CD34 cells enumeration is also very reliable, but it's technically challenging, costly, and time-consuming. So IRF is preferred nowadays. IRF can be used as an early marker for evaluating the regeneration of erythropoiesis, which I've already told you. The percentage IRF increases in few hours as compared to the reticulocyte count, which increases after 2 to 3 days. So this was a study, and we can see a graph from this study, which shows that IRF increases on the very first day in few hours after erythropoietic response, while the reticulocyte counts takes days to increase. Now, IRF can therefore be used to avoid unnecessary use of blood products. So if it increases, it indicates that the anemia will recover without using blood products, while if IRF remains low, it indicates ineffective erythropoiesis and a need for RBC transfusion. Now, next parameter is reticulocyte hemoglobin content. Now, reticulocyte hemoglobin equivalent or reticulocyte hemoglobin content, this gives you the current iron supply to the erythropoiesis, the current iron supply status of erythropoiesis. It lets you detect changes in the iron status far earlier than the HB content of mature RBCs. Now, in Sysmex, it is termed as reticulocyte hemoglobin equivalent, while in Siemens Advia, it is called as reticulocyte hemoglobin content. Both of them are equivalent parameters, and the range of both is 32.1 to 38.8 picogram. Now, advantages, of course, part of CBC, simple, reproducible, cost-effective, and not affected by acute phase reactants like ferritin and transferrin saturation. Now, reticulocyte hemoglobin content has been widely used to differentiate iron deficiency anemia and anemia of chronic disorders. It is also used in monitoring erythropoietin therapy and iron substitution. It's the earliest markers. It increases within 2 to 3 days of starting iron therapy. Now, reticulocyte hemoglobin content tells us something about functional iron deficiency also. Now, what is this functional iron deficiency? This is seen in cases of chronic inflammations, malignancies, chronic kidney diseases, where the reticuloendothelial iron stores are normal or high, but the iron is not available for erythropoiesis. So what happens in these conditions is that there is reduction in hepcidin, which is an iron regulatory hormone. Now, decrease in hepcidin leads to decrease in iron absorption from GI, decreased release from liver, and its recycling in RES. So RET-HE of less than 28 picogram more accurately predicts functional iron deficiency as compared to ferritin and transferrin saturation. Reticulocyte hemoglobin content also tells us about latent iron deficiency or iron deficient erythropoiesis. Now, what is latent iron deficiency? This is when there is no iron deficiency biochemically detectable. There is evident iron deficiency which is detected biochemically. However, overt anemia has not set in till then. It's important to diagnose this early, as it shortly progresses to iron deficiency anemia if not treated. Now, this is particularly important in pregnant females and infants who are prone to iron deficiency anemia. So RET-HE is very helpful to detect lack of an iron before overt anemia sets in. Now, let's see a case scenario. A 27-year female with twin pregnancy comes for routine ANC. An extended CBC along with other tests were ordered. HB, MCV, MCH was within normal limits. PBS was normocytic normochromic with few microcytes. Now, a look at the RET-HE showed that it was just 20.6 picogram. Now, this prompted the gynecologist to order for ferritin levels, which came out to be 6.9 nanogram per ml. So, without the initial alert by RET-HE, the female would not have been managed for iron deficiency anemia proactively, and this could have been detrimental for her and the twins. HE or delta hemoglobin equivalent. Now, this is a new biomarker seen it is derived as difference between reticulocyte and erythrocyte hemoglobin content. It's a real-time marker for an impaired hemoglobinization of newly formed retics. The reference range ranges from 2.3 to 3.7 picograms. The values above the normal range indicate an improvement in erythropoiesis after EPO or iron therapy, while the values below normal range for long periods indicate the onset of anemia. Now, delta HE is clinically used with the help of plotting a diagnostic plot called Hemaplot. Now, this plot is between ret HE and delta HE. It helps in the differential diagnosis of ACD and concurrent ACD and IDA patients. It is a quick disease monitoring tool before and after medical therapy in patients of ACD, IDA concurrent, and sepsis and malignancies. It's useful to identify non-adherent patients or insufficient therapy also. Now, what is Hemaplot? Now, Hemaplot is, as I said, it's plotted with delta HE on the x-axis and ret HE on the y-axis. So when this plot was made, it was seen that all the newborns, blood-healthy newborns, had negative delta HE, while all the blood-healthy adults had positive delta HE. Besides this, it was seen that all the cases of anemia of chronic diseases without therapy had negative delta HE, while all the cases of iron deficiency anemia had positive delta HE, although the ret HE in both the cases were the same. So this helped to differentiate cases of anemia of chronic disorders from those of iron deficiency anemia. Second point was that Hemaplot helps in the monitoring of therapy in iron deficiencies in chronic cases. Taking up a case of malignancy, a 74-year female had malignant melanoma. So on day 1 of diagnosis, it was seen that delta HE, this is day 1 of the diagnosis, delta HE is negative and ret HE is low. So after this, surgery was performed and chemotherapy was given. And on day 52, it was seen that the patient had normal delta HE as well as normal ret HE. So this is a normal quadrant of the Hemaplot. Another case of chronic inflammatory disease, 67-year male, diffuse MGN with nephrotic syndrome. This was when primary diagnosis was made, again in quadrant 7, when the delta HE was negative, ret HE was very low. It was followed by 58 days of medical immunosuppressive therapy. And what we got was here, item 8 in quadrant 5, which is the normal quadrant, that is the delta HE as well as the ret HE were normal. So this can also detect the compliance of patients, like in 15-year female with ulcerative colitis. Here was when the patient started with it. Primary diagnosis was done here. The delta HE was very low. And after treatment, after 32 days of therapy, the patient reached the normal quadrant. This proved that the patient was compliant as compared to this patient with 18-year with Crohn's disease, an 18-year female. Day 1 of diagnosis, the patient was here in quadrant 7, and after 145 days of therapy, again, the patient was seen in the same quadrant, that is the delta HE as well as the ret HE were very low. So this was a case of non-compliant patient. Now coming to the next parameter, that is automated immature granulocytes. Now these include promyelocytes, myelocytes, metamyelocytes. They're increased in sepsis, bacteremia, inflammatory states, steroid therapy, CA, trauma, MPD, and in late pregnancies also. So this parameter for the diagnosis of sepsis it is quick as compared to the blood culture. It is inexpensive as compared to CRP, PCT, lactic acid, interleukins, and it is definitely precise as compared to the manual counts. It's especially important in neutropenic patients, and it can sometimes be found as an unexpected finding in routine workup of patients. Reference range is 0 to 0.6%, and absolute values range from 0 to 0.6 into 10 to the power 9 per liter. Now here you can see a normal individual, a scattergram of a normal individual. Here we have a patient with a band over the neutrophil band of IG, that is immature granulocytes. And here we have a patient with immature granulocytes as well as high fluorescent lymphocytes. Now, immature granulocytes, more than 3% are very specific to predict sepsis. They can differentiate bacterial from viral infections. Early detection of bacteremia definitely leads to decreased mortality and morbidity and decreased healthcare cost. Now, it can be used to differentiate sepsis from non-sepsis systemic inflammatory response syndromes and lead to decreased inappropriate use of antimicrobials, which is the need of the hour. Neonatologists use band cells and IT ratio to rule out neonatal sepsis, which is now more precise and objective as compared to the manual counts. Now, immature granulocytes in COVID-19, there were many studies done on these, and it was found that IG count is associated with severity of COVID-19 infection. Greater the IG count values, greater was the severity and the criticality of the cases. Higher IG count values were found to be associated with longer duration of hospitalization. It is an independent prognostic marker of intubation and mortality in patients of COVID-19. Coming to the next parameter, that is nucleated RBCs. Nucleated RBCs are present normally in fetal circulation. Mean NRBC in first few hours of healthy term newborn are about 500 per mm cube. More than 1000 means the counts are elevated. By 12 hours of life, there is a fall by 50%. By 48 hours, there is just a count of 20 to 30 per mm cube. And by third or fourth day, virtually there are no NRBCs. However, they may persist up to 1 week in preterm newborns. Now, what are the advantages of automated nucleated RBCs over manual? So routine NRBC quantification has been added to the CBC itself. There is no need for reflex testing or new analysis. Substantial reduction in TAT because you don't need to prepare the smears. There is no manual counting needed. And this is especially important in cases of blood analysis of neonates. So manually, it is very difficult to detect NRBCs if they are less than 200 per mm cube, while on analyzers, we can detect even in counts less than 100 mm cube. So what are the causes of increased NRBCs? Physiological causes include the labor, vaginal births, preterm newborns, and their increase in NRBCs can be seen in chronic hypoxia from maternal smoking, growth restriction, maternal preeclampsia, maternal diabetes, besides the hemolytic anemias. They can also be seen in cases of Down syndrome, leukemia, and torch infections. NRBCs can be increased in case of acute hypoxia, subacute hypoxia, and postnatal hypoxia from cyanotic heart disease or pulmonary failure. Now, NRBC is used as a prognostic marker for infants with hypoxic ischemic encephalopathy. There is increased number of NRBCs, and this, if there is increased number of NRBCs, it is associated with increased risk of immediate postnatal complications. Higher number in first hour of life is associated with higher rates of neurodevelopmental disability at 2 years of age. More premature in infant, higher the NRBC count at birth. Higher the NRBC in preterm infants, higher are the rates of adverse neonatal outcomes like NEC and PGA. Also, early onset neonatal sepsis is associated with high NRBCs, and they correlate well with IL-6 concentration in septic infants. In pediatric as well as in adult ICU patients with NRBCs, they are associated with high mortality, especially if the counts are more than 2000 per microliter. So it is used as a marker of severe illness, and it can be used for daily monitoring of critically ill patients. So this was a study done in NICU patients, and it was seen that neonates with 0 NRBCs had very low mortality percent. As the count of NRBCs increased, so did the percentage mortality in neonates. Another study in case of medical ICU patients, it was again seen that as the counts of NRBC increase in blood, so does the percentage of mortality. So here we have 8 out of 193 patients, and here we have 18 out of 20 patients facing mortality. So there were many other studies, and these examples and many others show that the presence of NRBCs in the CBC can serve as an important clinical warning. So last of all, we come to immature platelet section. Now, immature platelet section represents the most immature platelets recently released from bone marrow. They're larger in size with greater content of RNA. That's why they are also called as reticulated platelets. The lifespan of mature platelets is 7 to 10 days, while that of immature platelets is less than 1 day. And hence it reflects the activity of megakaryocytes. The reference range is 3.4 to 18.4 into 10 to the power 3 per microliter. This is the absolute one, while the percentage is 1 to 7%. Now, it is used to distinguish thrombocytopenia due to bone marrow failure from thrombocytopenia due to peripheral destruction at any particular platelet count. Now, here we can see a normal individual with normal platelet count and very little IPF fraction. Now here, the platelet count is reduced, as you can see, but the IPF fraction is increased. And this is seen in cases of destruction, peripheral destruction. While here we can see that there is thrombocytopenia, but there is no IPF fraction. So these are the cases of production disorders. So thrombocytopenia can be differentiated on the basis of IPF into high IPF and low or normal IPF thrombocytopenias. High IPF cases are seen with peripheral platelet destruction like ITP, TTP, DIC, and a subset of MBS, while decreased marrow production is seen in cases of low IPF patients. So these are the cases of aplastic anemia and cytotoxic chemotherapy. So now the role of IPF in dengue. IPF has a strong correlation with recovery of platelet count. It can be used confidently to predict the recovery of platelets. And IPF more than 10% indicates recovery of platelets within 48 hours they will be seen a rise of 20,000 per microliter in 48 hours if your IPF is more than 10%. So it's a reliable guide for decisions concerning platelet transfusions, and sometimes these transfusions are done injudiciously in cases of dengue patients. Now, prophylactic platelet transfusion can thus be deferred, and also the hazards associated with it. So to monitor and evaluate thrombocytopenia in patients with dengue, IPF should be considered as a routine practice. Now here we can see that as the platelets are decreasing, the IPF is increasing. And once IPF has reached its peak, after that, they starts the recovery of platelet count. So it is also used as an indicator of imminent platelet recovery after cytotoxic therapy or post bone marrow transplant. IPF levels more than 7% define bone marrow recovery. It occurs on an average 3.1 days earlier than platelet count recovery and 3 to 8 days earlier than ANC recovery. So it's a useful and early guide of bone marrow recovery and limits unneeded prophylactic platelet transfusions. IPF is also an early predictor of sepsis. And thrombocytopenia is usually seen in cases of severe infection and sepsis. And the main physiology behind this is increased platelet consumption because of the procoagulant response. Now, increased IPF levels correlate with infection as determined by the positive blood cultures, even when patients were non-thrombocytopenic. So it indicated a subliminal platelet consumption. So IPF increased before the onset of sepsis by a median of 2 days. Now, IPF in MDS patients. Most patients with MDS had normal IPF, but a subset in one of the studies, about 24% of the patients of MDS had IPF more than 10%, with platelet count 50,000 per cc. Such patients showed that there was chromosome 7 abnormality in their cytogenetic studies. So an aberrant increase in immature platelet fraction in patients with MDS is a marker of karyotypic abnormalities associated with poor prognosis. Now, finally, IPF is used these days in cases of coronary artery disease also. Recent studies have shown that patients with reticulated platelets have an adverse risk in cases of CAD and stroke. High IPF is associated with resistance to antiplatelet therapy also. Now, physiology behind this is that IPF, the immature platelets, they are more active biochemically, so they cause increased platelet aggregation. The reactivity of these platelets is more, the surface receptor expression is more, there is more RNA, there is more prothrombotic transcripts. Thromboxane A2 is larger in amount. So an increase in IPF in cardiac patient is associated with insufficient response to antiplatelet therapy. It increases the cases of MI in such patients. There is increased number of deaths. There is increased revascularization and increased cases of stroke in such patients. Now, high risk and diseased population also showed that there was increase in IPF levels in their blood. These high risk patients included sepsis, ACS, CAD, chronic coronary artery disease and acute coronary syndrome, and stage renal disease patients, post-surgical patients, diabetic patients, and smokers. All these had high levels of IPF in their blood. So take-home message is that CBC from latest hematology analyzers have a plethora of information to offer us. So let's spend a few minutes to read, analyze, and interpret the information and guide our clinicians to use it for better patient management. Thank you.
So we move from what is new to what is the most basic. What is in a peripheral smear? And I'll be restricting myself to peripheral smear in anemias. And why anemias? Okay. So this is a National Family Health Survey of the last national NFHS survey 5, which shows that more than 50% of children and more than 50% of reproductive adult females are anemic. And interestingly, even in adult males, as is our misconception that males do not become anemic, in our population, approximately 1 in 4 or 1 in 5 men are also anemic. So why goes too far? So most of us who are any clinics, any laboratories they're working in, 2/3 of the females would have a low hemoglobin, half of the kids would have low hemoglobin. So what can we do sitting in our labs anywhere? Because we can talk of anything, but that's what is our reality as a country. We are amongst the 35 countries listed by WHO where anemia is still a public health problem. And I also took up these statistics because we made talk of we are developing, but diabetes and hypertension are there in our population, but they still are nowhere close to what anemia is with us. And why we need to talk of anemia? Because it reduces productivity of this age group people. Females working home, working at the offices, their productivity reduces, their cognition reduces. The kids, they have stunted growth, they have reduced cognition, reduced attention span. So that's real anemia. So, and interestingly, it's increased from the last survey, which is not too far with 2015-16 survey. It has increased even though the government has started the anemia mission in 2018. So I just brought this up to remind ourselves that the CBCs that we are doing, a lot of them have a low hemoglobin, and can we do something to make them feel better with the most basic things that we have, which is just a basic cell counter, 5-part differential counter, and a peripheral smear. So this is the class. What is anemia? What defines anemia? So in non-pregnant females, it is anything less than 12, pregnant female less than 11, and children, the specific reference ranges are different, which I have not picked up here. And in men, less than 13 is a low hemoglobin. So whenever we see a CBC, how do we go about approaching it? So step 1 is whether it is only a low hemoglobin or there are other counts which are also abnormal. So basis which are differentials, our approach becomes a little different. So if it's only anemia, we look at the MCV and we first see whether this anemia is normocytic normochromic, which with normal red cell and dialysis, a microcytic hyperchromic anemia with an MCV of, by standard practice, anything less than 80 femtoliters, and an MCV more than 100 femtoliters defines a macrocytic anemia. But in practice, a lot of patients have a normal MCV but a wide RDW, so which some of the cases I'll be discussing in my presentation. So none are in black and white. What we see in practice is commonly multifactorial, and we have to reach it in that manner. And that's why the smear examination becomes very important, because what the counters gives us is an average of those millions of red cells that is there. But what we need to tell the patient or the clinician is from the spectrum of cells that we see on the slide. So sadly, I mean, in the last, whatever experience I've had, unfortunately, smear examination and smear making per se is losing its importance by the name of automation, saying that counters can give everything. But we have to understand counters give an average or any statistics, mean or median or whatever. They don't give a glimpse of what is going on in the red cells. The smears do tell us a lot. I picked up some interesting cases which are from the routine practice. This is a 40-year-old female with a hemoglobin of 4.7. So not needing a mention that 4.7, how good she would be in her daily routine activities. And her normal TLC, normal platelet count, normal differential count, But a red cell indices are microcytic hypochromic and MCV 59.6 femtoliter. And this is the peripheral smear. So how do we describe this peripheral smear? This is the stand. I mean, if I go into how we report a smear, we have to report it under all heads. So RBCs, WBCs, platelets, hemoparasite, and anything additional that you see. But what I've done is only picked up the salient features in the smears. These are microcytic hypochromic red cells with a moderate NI. So that is, the cells are of different sizes. And there are some poikilocytes, cells of different shapes. There are some elliptocytes, some target cells. So this is a standard microcytic hypochromic anemia, and that's how classical iron deficiency anemia looks like. That's like you see cells of varying sizes, some small, some big, some less hypochromic, some more hypochromic, and it's a standard microcytic hypochromic anemia, standard iron deficiency anemia. So it is good to write what you feel on the peripheral smears, because a reality of our country is also that most patients cannot afford a huge list of investigations if we advise to them. If we tell them that most likely it is this, and you do only an iron studies, and that comes out to be correct and the patient gets treated, then if there's no burden on the patient's pocket. And why would that patient not turn back to the laboratory? He will, because he knows that we told her why she had such low hemoglobin. And even if the patient does not do an iron study, or the clinician does not do an iron study, an iron tablet would most likely help her, that you also know and the clinician also knows. So it's important to write, it favors this. The serum iron study is done showed that it was a standard iron deficiency anemia. So serum iron has studies conventionally has these 3 parameters. There are a lot more that have come up, but unfortunately they are not available to most of us. So, but standard iron deficiency anemia, which constitutes approximately 60 to 70% of anemias till date also in our country, can be diagnosed by the standard iron study, which has only these 3 parameters: serum iron, total iron binding capacity, transferrin saturation, and serum ferritin. Good to do it, but again, since it's an expensive test, may not be able to do it. But a peripheral smear saying that favors iron deficiency does solve a lot of problems. I just picked this up from a textbook, that how one goes about interpreting serum iron studies. So the common differentials which we need to differentiate by iron studies are this iron deficiency and anemia of chronic disease. So one thing that is to be remembered is that TIBC is either normal or low in chronic disorders and high in serum ferritin. And in our country, since iron deficiency is very prevalent, many patients have both of these. And in these patients, iron, even though their stores are not replete, they will respond with difficulty to the iron, because their milieu is not conducive to iron replete hematopoiesis. So it's important to pick these up. I'll discuss how to pick this up on the smears. Smears do talk a lot. It's another male patient, hemoglobin of 7.4, mildly elevated white cell count, and a normal platelet count. IBC indices are again microcytic hypochromic, a low MCV, MCH. This is how the smear looked like. So what do we see? Spot on is a lot of target cells. So impression is that it is a microcytic hypochromic anemia target cells. So when do we see target cells? There is a huge list that is given in the books. So a thalassemia trait, a liver disease, and many other hemoglobinopathies as well. But so we spoke to the patient. The differentials on the morphology will be it's either hemoglobinopathy or it is a liver disease. Now this patient turned up, fortunately, I could retrieve the history from the doctor. That patient is on ATT. So what is happening here? Because of his anti-tubercular therapy, his liver is getting affected. And that's this is what the smear is showing. So a smear is a window to the systemic functions. And it is important to advise HPLCs if not done earlier, because this patient is a 28-year-old male and might not have completed his family's yet. So it's the same picture in a 50 to 60-year-old male. We do not need to advise anything, because even if we diagnose him as having a hemoglobinopathy, it does not contribute to anything, because he's not going to have children now. brief about anemia of liver disease. There's a lot of things that happen in liver disease. So liver disease anemia is multifactorial. A good pointer is that if you see a picture where everything is there, target cells are there, there are polychromatosis, there are macrocytes, it's likely that the patient would have a liver disease, and it's good to describe all of those things. And sometimes you may be able to retrieve the history. If in the same lab, this patient is a regular patient who gets liver function test also done, then your smear also helps it. Sometimes blood loss anemia, iron deficiency, or folate deficiency can be supplemented and patient can be made to feel better. The 30-year-old male, hemoglobin of 5.4, a male with hemoglobin of 5.4, and indices again microcytic hypochromic. This is the smear picture. Looks like a standard iron deficiency anemia, and this patient also had eosinophilia. So I brought this up just to emphasize that in our scenario, males also have iron deficiency anemia. And in every case, like in West, we do not need to do a colonoscopy and look for a CA colon, because in a family where child is anemic, child is nutritionally deficient, then the male also can be nutritionally deficient. So that is very much feasible. Common things first. This patient had a microcytic hypochromic anemia with eosinophilia. So he had worm infestation. So in our scenario, males with iron deficiency anemia causes remain essentially the same. So deworming with an iron supplementation will most likely work for this patient. And then he may have a liver disease with varices and piles, from which he is bleeding, or he may just be nutritionally deficient. The family's diet is not appropriate. So that's it. Just to highlight that 1 in 4 and 1 in 5 of our males are anemic. Just a reiteration that although the list in the books is too extensive, the most common causes and practice remain just these 3. And for the third one, we can't do much, but for the first 2, a lot can be done. So it's important to try to pick up the differentials when we see a peripheral smear. Special case scenario, this is interesting because in our country, although books write that you do reticulocyte upfront in a patient of anemia, but reticulocyte count practically is not available in most laboratories. We don't have to go too far to figure out that. We will actually have to find labs where retic is done. So it cannot fit into our scenario. But if you see a peripheral smear with a microcytic hypochromic picture with a lot of polychromatophils, you do see them on the smear itself, then this patient is either having this anemia because of the blood loss, and it also happens if the patient started on therapy. This 4 hemoglobin patient, if goes back to the doctor and doctor gives him her hematinics, then the next time he comes, even though his hemoglobin may not have risen, you may see a lot of polychromatophils. So this means that this patient doctor started the therapy. And less common is a paroxysmal nocturnal hemoglobinuria, where you see a microcytic hypochromic anemia with reticulocytosis. And in another, since we discussed an iron patient on therapy, I would also like to highlight one which we have commonly seen in practice, a patient with 11 hemoglobin and RBC count of 6 million. You look at the peripheral smear, there's standard iron deficiency with a moderate poikilocytosis, no nucleated RBCs, high RDW. So when IDA patient, iron deficiency by prima facie has low erythropoiesis, low red cell count. But when you give iron to them, then hematopoiesis accelerates and it overshoots the normal. So you see them, and if you see them for the first time, you will feel that this could be a thalassemia trait or hemoglobinopathy. But when you look at the smear, it is showing more in isopoikilocytosis than you see in a thalassemia trait. Then you need to go back, or you at least need to keep it in mind that my morphology is not lying. This is an iron deficiency anemia, but maybe the patient is bleeding from somewhere, or the doctor is already supplementing him or her with iron. This is a young male, 77 gram per deciliter hemoglobin. But here, move on to the next group of anemias, that is an MCV of more than 100 femtoliters, that is a macrocytic anemia. This is how the picture looked like. So when we identify, just for reiteration, that when you look at the size of red cells, you compare it with the nucleus of a small lymphocyte, which since every field does not have a lymphocyte, I couldn't catch one in these fields. You see these macrocytic red cells along with this polychromatophores. And the WBCs, you see this hypersegmentation. So macrocytic anemia with some ovalucytes, some poikilocytes, and hypersegmented neutrophils. So when we approach a macrocytic anemia, they're classified into two broad categories, megaloblastic and non-megaloblastic macrocytic. So which means that megaloblastic means that defect is in the hematopoiesis level. There's the asynchrony between nucleus and cytoplasmic maturation. That's why this product that is coming out from the marrow is bigger red cells. Those are the megaloblastic causes. And hypersegmentation is seen in megaloblastic macrocytic anemia. So again, the smear itself can narrow down the differentials and eases the life of the clinician, the patient, and the laboratory person as well. You see hypersegmentation, macrocytes, macrovalucytes, it is a megaloblastic macrocytic. It's not necessary to see a megaloblastic nucleated RBC because hypersegmentation is also indicating that defect is in the nucleocytoplasmic maturation process. So this is a macrocytic anemia, favor megaloblastic, and upfront you can advise, since it's a young male, and megaloblastic anemias do cause a lot of problems, neurological problems other than anemia, although that is per se a feature of anemia also. But you can upfront say that do vitamin B12 folate assay or a therapeutic trial and follow-up. So again, the therapeutic trial, I don't want to discuss the academic classification of therapeutic trial because that doesn't work in practice. Easiest way is to tell the doctor, give B12 and folate and do a repeat hemogram after 5 days. You will see increased reticulocyte count or polychromatophilia in the peripheral blood. You see, so just to highlight, this is the kind of cell that's a polychromatophil. This is a grayer shade than rest of the RBCs. That's how polychromatophils look like. Just a reiteration that macrocytic can be megaloblastic and non-megaloblastic. One thing that is in practice, one must remember that megaloblastic can be just a window of something even worse sitting in the bone marrow, in the hematopoiesis. So basically, if the marrow is proliferating too much because of any cancer or because of hemolytic anemias, then the demand of the cells for folate increases. And then what we see is the red cells which are megaloblastic macrocytic. This is important because I've burnt my fingers many a time. The standard, very classical PANS megaloblastic anemia, which is showing macrocytes, ovalucytes, NRBCs, cabo rings, basophilic stippling, everything, and you write it megaloblastic and what it turns out to be. And it's important to remember this. Just have a look at this. A macrocytic, more macrocytic, neatly macrocytic than the previous case. And you see these hypersegmented neutrophils. So this patient was a patient of CML who was on treatment. So this is a therapy-induced megaloblastic anemia. So nothing needs to be done for this patient by the doctor. But since in the laboratory we don't have the picture, we can just identify and write it. And this patient had a low HP, very low platelet count, classical megaloblastic anemia. But this is a megaloblastic anemia, but therapy-induced. We won't write a B12 folate assay for this patient. A very common practice is a combined deficiency. I just wanted to highlight this because what is combined most of the times is important to know. Combined is usually folate and iron because the folate stores are less and the sources in the diet of iron and folic acid are similar. Both come from green leafy vegetables. So they both become deficient together. So you see a combined picture very frequently. A very important good sign is you see a hypersegmentation along with a microhyper picture. That's most likely a folate deficiency. Second thing, which I myself have seen a patient with a 4, 5, or 6 hemoglobin, a standard iron deficiency anemia. You give iron, hemoglobin increases to 11. You do a smear again. You see the smear full of macrocytes, ovalucytes, standard megaloblastic. So what has happened? Folate was not initially deficient, but when you gave only iron, marrow's demand for hematopoiesis increased. It needed more folate. And then secondarily, folate became deficient. So there's no harm in empirically giving iron and folate in practice. That's what clinicians do most of the times. And that's the logic behind it also. A 50-year-old male, another macrocytic anemia, but this time the platelet count is also low. Macrocytes, macrovalocytes, and what do we see in WBCs? These are hypolobated dysplastic neutrophils. Macrocytic anemia, with or without other cytopenias, in early age, keep in the mind myelodysplastic syndrome, though it cannot be diagnosed on the smears, but it can be suspected only on the peripheral smears. Because every patient should not be going around doing a bone marrow, but picking up these dysplastic neutrophils is important. Another patient, similar blood picture, hypolobated dysplastic neutrophils, but here the red cells are normocytic normochromic. This is again an elderly male, 71 female, 71-year-old female. So both these smears, we suspect the myelodysplastic syndrome and advise further workup. And in further workup, one would rule out vitamin B12 folate assay as a standard practice. It's important. It's important to keep ourselves safe by writing that rule out secondary dysplasia, because we have seen tuberculosis patients presenting with marked dysplasia, smear full of pseudopelvic neutrophil, which is treatment induced basically. So always when you see dysplasia, it's important to write, please look for the clinical history. Another last group, normocytic normochromic anemia. So here we picked up some cases, and it's looking at a normocytic normochromic smears, even when they're not very low hemoglobins, it is very interesting. So what do we see here? Spherocytes and polychromatophores. These small cells, fully hemoglobinized, are the spherocytes. These gray cells, looking somewhat like these bigger cells with gray color, these are all polychromatophores. So standard picture of a autoimmune hemolytic anemia and hereditary spherocytosis. And so that's what this patient had both a low hemoglobin and a low platelet, but it could just have been a low hemoglobin also. The spherocytic anemia. And if it is associated with a low platelet as well, then it is called an Evans syndrome, autoimmune hemolytic anemia with thrombocytopenia. And on going back to the patient, this patient turned out to be APLA positive. So what does it mean? It just means that this patient has a generalized autoimmune disorder. So APLA is a part of that autoimmune disorder, and hemolysis is also a part of it. And how do we diagnose or confirm a hemolytic anemia? Is by doing the Coombs test, direct and indirect. And in an autoimmune hemolytic anemia, DCT would be by convention strongly positive. A 3+ or 4+ DCT positive. Why I'm mentioning this here is that a low grade 1 or trace positive DCT is not important, because that could happen because of coexisting infections, hospitalizations, and a lot of other things. A strong positive direct Coombs test is what is confirmatory for an autoimmune hemolytic anemia, and we do see this. It is frequently seen in practice. It's not rare to see them, but we have to see our smears well, and we keep all of these things in mind, that these things happen in the smears. So this patient had a SLE with, and this picture was a part of the whole autoimmune conundrum. Another female, a normocytic normochromic red cell indices, very low hemoglobin, 4.9 gram per deciliter. And this was very interesting. Is what do you see here? A 4.9. This is the only history I got. Patient anemia and the cell counter slip. What we see on the smears are these stacks of red cells. These stacks of red cells are the rouleaux. So if this picture picked up, because you see that these red cells are separate from each other, and alongside we can see these rouleaux. So what does it? Why is this important? Because normally in a smear in the body and tail we do see rouleaux, but with the tail end where other red cells are separate from each other, we are seeing rouleaux. Then those rouleaux have clinical significance. Normocytic normochromic anemia with rouleaux. Theoretically, there can be many causes. But what is important is to not miss a multiple myeloma. So after this history, the doctor went back to the patient. Patient was complaining of back pain. It's not uncommon in our country, in our population to have back pain. Every other person has back pain, either due to sedentary work or anything. Every other person has back pain. But this female's back pain was myeloma, which was confirmed on specialized investigations. But see, a 4.9 hemoglobin patient would be having a lot of symptoms because of myeloma, would be having a lot of symptoms because of the anemia per se. Would keep on eating him, having hematinics, empirical hematinics, but only a peripheral smear examination could be so effective in triaging the patient well. Just saying that this is not new, like nutritional is also, it may also be enough. So another patient, microcytic hypochromic indices, middle-aged female, 7.6 gram hemoglobin. Okay, this is something I really want to bring out. This was a 25-year-old female. This is the picture of, this is the smear picture. So this is moderate. How would we describe it? A moderate and isopoikilocytosis, some target cells, some teardrop cells, some of these electrocytes here. But you also see these NRBCs. So this patient had 4 enucleated RBCs per 100 WBCs. This is a picture of a thalassemia intermedia. Thalassemia intermedia is a clinical terminology, which means a thalassemia which is presenting in adult life, so not presenting after 3 years of age. So in middle age, we do see thalassemia intermedia. So keeping this in mind can help us. If in a standard practice you advise serum iron studies, ferritin and HPLC, that may be picked up. And on HPLC, it may just turn out to be thalassemia, heterozygous thalassemia, because thalassemia intermedia is a clinical terminology. At laboratory level or at genotypic level, it may be a lot of things. It's important to keep it in mind because these patients should not be given empirical iron and folate. The folate is needed at some time point, but iron is not at all needed for them. They will be already in, it is thalassemia intermedia, which has most iron overload, more than thalassemia major also. So it is important to not give them iron. It is important to see these nucleated. If you see nucleated RBCs, you do not see an iron deficiency anemia unless it is a 3 or 4 hemoglobins. You see an RBCs and a microhypo picture, it's not iron deficiency, it's something else. So this is all in the smears, and so this is the smears of microhypoanemias. Now this is another patient who just got these up because these are all from the standard routine practice that we see all of this. You see these polychromatophores. Even if you don't have a retic count in your lab, this gray color stands out from the smear. Polychromatophores and spherocytes. So spherocytic anemia has 2 differentials: hereditary spherocytosis and autoimmune hemolytic anemia. So this is also, I would like to highlight that we sometimes is kind of assume that these diagnoses are only in the books or are rare to find. I've seen it way more often than I myself had expected. What do you see in this field? This is a round cell with a bite here. So it's typically a biscuit bite, a biscuit-like cell with a bite. And this patient came with a hemoglobin of only 11, and we see a lot of these. But since this patient was a regular follow-up, we went back to the delta check and we saw that around 2 months back, her hemoglobin was 14 gram per deciliter. So what has happened in these 2 months that her hemoglobin dipped down? So although she might be having a 12 HP, 11 is not important. She might be having a 12 HP, and you see this smear with bite cells. A dip from 14 to 12 is happening because this patient developed a skin disorder, was started on Dapsone, and Dapsone causes hemolysis in G6PD deficient individuals. So it's important to keep our eyes open. We are said to be doctors, a pathologist. I mean, when I started my MD, you were told that pathologist is a doctor. We actually are doctors. We can tell the doctor, so see what is happening. Something is not there right on this map. This is a microangiopathic hemolytic anemia, and this patient was a 50-year-old male who had a walled replacement surgery, and his hemoglobin was hovering always around 6.7, and he had a lot of these fragmented cells. So we again have a clinching diagnosis on the smear only. No additional tests are required. And a low hemoglobin can be a real pain for the patient and the doctor trying to find a cause. No bone marrow, nothing can diagnose these patients. G6PD deficiency, microangiopathic hemolysis, phagocytosis, no. If you straight away send him to some place saying कि bone marrow करना पड़ेगा, the patient को कभी diagnosis नहीं बन सकता. And he'll keep on roaming around just like that. So it's a cold agglutinin. So here, one thing I want to highlight is that although cold agglutinin disease is a non-phenomena, but in winter we see this very commonly with a otherwise normal dialysis in normal patients. The technician comes and says a sample bar clot ho raha hai. You draw the sample in the clinic, sample clot ho raha hai, but actually it's not clot. These are all gross clumps, big agglutinates. Warm the sample, it cleans up a bit, but it can be a real pain to collect the sample and run it if the patient has too many cold agglutinin. So, but all of them do not have a hemolytic anemia. Many of them are just benign cold agglutinin sitting there because of some transient infections, some viruses which are also common in winters, or nothing at all. So there the importance is not clinical, it's more of a laboratory problem because you cannot run the sample on a cell counter and give a good count. So even after warming, it doesn't clean up many times completely. This is just another picture, sickle cells on the smear. And this is just for revision. This is a post-prenectomy smear. So post-prenectomy smear is a smear where you see the red hemogram is normal, but you see the smear, you see everything that you have seen ever. Fragmented cells, spherocytes and poikilocytes and all jolly bodies and crenated cells and all. And if you are lucky enough, you can be able to go back to the patient. Patient will tell, my splenectomy was done some time back or long back or something like that. Just to highlight that sometimes a picture like this can also come where we see a very high TLC of mildly low HP, but actually it's just a hemolytic disease of newborn or RH incompatibility, which is a lot of NRBCs which are causing a high TLC, but it's actually just anemia. Just to highlight why one should see the smears. So again, no history patient, low platelet and a low HP, smear of large. Just smear examination is something that should be a religion to a pathologist or pathology lab, and we are increasingly becoming more automated and more fancy and forgetting our basic stuff, but that basic is the most fancy, I would say. Thank you.